بسم الله الرحمن الرحيم. في معانا في ما يخص الباطنة في 4 محاضرات حتكون، ونبتدئها أولا بالبروتينوريا والنفروتيك syndrome. First of all, we have to speak about the proteinuria. Proteinuria in general is not a disease. You cannot say the patient you are or your diagnosis is proteinuria. Proteinuria is a sign of different diseases. But first of all, we have to know how to define proteinuria. Not anyone who is passing you protein in the urine, we can say, this patient is having proteinuria. No, proteinuria can be defined as an amount of protein that exceeds 300 milligram per day. That means we have to ask the patient to urinate and collecting his urine and measuring his protein in 24 hours. If the protein exceeds 300 milligram per day, we say you are having proteinuria, definite proteinuria, and this need further investigation, further evaluation to manage it. But we have also first, patient with proteinuria can also present with what is called microalbuminuria. And microalbuminuria is amount of protein between 150 to 300 milligram per day. When the patient is collecting urine and we measure the protein, and the protein is between 150 to 300, we can say to the patient you are having microalbuminuria, or the patient is having microalbuminuria, and this is an alarm sign for different diseases. Okay. Significant is if the patient is passing more than 300 milligram, but between 150 to 300 is alarming. And we also should know why this patient is having this amount of protein in his urine. Patient can have certain condition in which he will lose protein. That means when we are checking protein by dipstick in his urine, we will find it positive. First, we have to exclude conditions. It's not a disease in general, but it is a condition, or it is a temporary condition. We have to exclude it. If the patient is having fever and we measure by dipstick his urine, we can find proteinuria, positive proteinuria. If the patient is having urinary tract infection and we measuring by dipstick, also we can have proteinuria, and this can be disappear. This proteinuria can be disappear or become negative after solving the problem, or after the urinary tract infection has been properly managed. Patients who are exercising, anyone who has played football, any type of sport, exercise, and then we check his protein in urine, probably we will find that he is having proteinuria by dipstick. Also in pregnancy, we have to exclude or consider that the patient may have preeclampsia manifested by proteinuria. and this proteinuria can be improved or disappear after delivery. And if the patient have a female patient or having vaginal discharge, and this vaginal discharge is contaminated by urine, and we check the protein in the urine, we can find that this patient is having proteinuria by dipstick. So we have to keep this condition or temporary causes of proteinuria in our mind. That that means we have to prove whether the patient is having any or more than one of these conditions. Okay. Right. Proteinuria, as I mentioned before, is not a disease. You cannot say this patient is having his disease is proteinuria. No. Usually proteinuria is a consequence of different diseases, and these different diseases can be primary, and it's called glomerular disease, such as proliferative glomerulonephritis, primary, or secondary. And these secondary causes if the kidney is involved in certain systemic diseases. Which systemic disease? Again, primary in the glomerular disease, or systemic diseases that we should know that in this systemic disease the kidney can be involved and developed proteinuria. The most important one that can cause disease is diabetes mellitus. And diabetes mellitus, as we mentioned in previous lectures, can be complicated by micro and macro complications. One of the microvascular complications is called diabetic nephropathy. And diabetic nephropathy is typically manifested by proteinuria. This protein level is elevated or is not normal. Also in connective tissue diseases. Example for connective tissue disease, and only in connective disease if the kidney is involved. A typical example for that is systemic lupus erythematosus, SLE. SLE, as we know, can be manifested or associated with nephritis, and this typically patient present with nephritis due to SLE typically present with proteinuria. The third one is vasculitis. Vasculitis, if the kidney business has been involved and inflamed, vasculitis can not only affecting the kidney, it can affect any organ. But if the kidney is involved, patient can also present with proteinuria. Amyloidosis, amyloid deposition on the kidney can be also associated with proteinuria. Myeloma, this is a malignant disease, multiple myeloma, and we mention it in the hematology that multiple myeloma can be, or symptomatic multiple myeloma are associated with kidney involvement with proteinuria. Congestive heart failure also can be associated with proteinuria. Hypertension, bacterial endocarditis can also be associated with bacterial. These are systemic diseases, and we as a doctor should know them all to exclude any one or include any one of these systemic diseases. Or then it can be primary, as I mentioned, glomerular disease. Cause is unknown, as in proliferative glomerulonephritis, and this is usually diagnosed by biopsy. Patient who has been presented to you and you find that he is having proteinuria, or he would like to know whether he is having proteinuria or not. We have to check his protein by deep stick first in 3 separate occasions, and these all 3 separate occasions should be positive with protein. That means it should be manifest with proteinuria. And the analysis of protein here it to be more accurate to diagnose in any time, because as we mentioned, in certain condition, patient who is exercising, who is having fever, who is having tract infection or whatever, can be present with temporary proteinuria. It's not a big problem. But if the patient is not having any of these conditions and he is having in 3 separate occasions, in morning sample, patient are not involved in physical activity because there is orthostatic proteinuria. So we can say that this patient is having proteinuria and looking for the cause. Then furtherly, we can looking to the cause of proteinuria. If we are confused, this patient is having orthostatic proteinuria, so we have to take 2 samples. One taking in the daytime and one is on overnight. The first one 7 to 11 p.m. and the other one 11 to 7 a.m. In these 2 samples, if the patient is having true proteinuria, in these 2 samples, he also should have protein or elevated protein in his urine by deep stick, or positive protein by deep stick examination. If not, if the patient is having only on the daytime and over the night is not, so the patient is having orthostatic proteinuria. If we would like to know whether the proteinuria is of glomerular in origin, we have to perform the following. First, urine microscopy. And then, and this is the most important one, is urine collection in 24 hours and measuring albumin in 24 hours collecting urine. It should be elevated. And then check his serum creatinine, albumin, cholesterol, and blood glucose. Looking for the cause here. Here we are looking for the cause. Why this patient is having proteinuria. And then autoantibodies, antinuclear antibodies, anti-double stranded DNA antibodies. These are for diagnosing of SLE, hepatitis B, serology of hepatitis B, hepatitis C, HIV can be also done if we did not find other cause. And plasma protein electrophoresis or urine electrophoresis to diagnose multiple myeloma as a cause of proteinuria. Should we do this all? No, if we find that the patient is having elevated urine and then he is having diabetes mellitus on the same time, it's more likely to be diabetic nephropathy. If we find that he is having elevated protein in 24 hours collected in urine, and he is having anti-DNA antibody, anti-double-stranded DNA or anti-Smith antibody. That means he is having SLE. And so, if he is having positive electrophoresis for multiple myeloma, plasma cells are increased. So here we should know that this patient may have or is having multiple myeloma, and this is the cause of proteinuria. Why proteinuria can be complicated, or proteinuria can be serious, and can be, proteinuria is innate, can be complicated or can develop complication, or it has its consequences in association with the systemic diseases. I mean, the systemic diseases can cause complication, and the proteinuria in it, that you are passing protein more than normal, so you can develop complication. This complication, we will mention it as pulmonary edema due to fluid overload, renal failure, intravascular depletion. Yeah, the patient is having overload, fluid overload, but intravascular, it's hypovolemic. Okay? He is having fluid overload, but extravascular. Intravascular is depleting. Depletion of intravascular fluid will cause renal failure, and it's called pre-renal renal failure. Patients who are having proteinuria can develop bacterial infection. His immunity is decreased, so he can develop bacterial infection. Patients who are having proteinuria can develop DVT or even arterial thrombosis or occlusion. Deep vein thrombosis or arterial occlusion due to increased coagulopathy. And cardiovascular disease also can be complicated by proteinuria due to hypercholesterolemia. So in general, proteinuria or patient with proteinuria dependent on the level of protein. If the level of protein is markedly elevated, reaching the nephrotic range proteinuria, he can develop all this complication. If not, he can develop one or less of this, all or less of these complications. And that's what I mentioned before here is the nephrotic syndrome. Nephrotic syndrome is defined by the presence of nephrotic range of protein in 24 hours collecting urine of more than 3.5 grams. This is essential to diagnose that this patient is having nephrotic syndrome. We can use this terminology, nephrotic syndrome, if the patient is passing more than 3.5 gram protein in 24 hours collecting urine in the day. And a consequence of this proteinuria, high level of protein that is passed by the urine, patient can develop edema due to fluid overload and hyperlipidemia, and also logically the patient can having hypoalbuminemia. He is passing more protein, that means albumin. So here his blood level of protein or albumin is decreased. This is typically. So nephrotic syndrome is characterized by the following. Proteinuria more than 3.5, and this is essential in 24 hours collecting urine. And consequence, logically, this patient can develop, or he will develop, or she will develop edema, hyperlipidemia, and hypoalbuminemia as a consequence, as a complication of this high level of protein that is passed by the urine. What are the clinical features of nephrotic? Usually patients with nephrotic proteinuria are having these typical clinical features. Puffiness around the eyes, characteristic in the morning when the patient is getting up and looking to the mirror, or anyone looking to him, he will find that his very orbital area is puffy. So puffiness of the eye due to fluid accumulation. Patient also can note that he is having swelling of the lower limb, and by examination you will find, as a doctor, you will find pitting edema, lower limb pitting edema. Patient can also develop, or as clinical features, fluid collection in his pleural cavity called pleural effusion, and this is manifested by chest pain, can be shortness of breath, and by exam, when you are examining the chest of this patient, you will find decreased breath sound in that area and stony dullness on the area of the pleural effusion. Patient also can develop ascites, peritoneal, the fluid in his peritoneal cavity, it's called ascites. And ascites, as a symptom, patient will complain of abdominal distension. By exam, you will find that patient is having abdominal examination. Patient will have, when you are examining him, you will find that he is having, or she is having, positive shifting dumbness, and occasionally, if he is having tense ascites, transmitted thrill. When you are measuring his blood pressure, you will find that he is having hypertension and foamy urine by urination. This foamy urines, or this foamy character of urine, is due to elevated level of albumin in the urine, and the appearance of the urine is foamy in this situation. This slide, lower limb swelling, and if you examine this one, you will find that the patient, or this one, is having pitting edema. Here the puffy face, mainly on the periorbital area. You have to look for the periorbital area. It's very characteristic of patient with nephrotic syndrome causing a hypoalbuminemia. So this patient may have an osmotic balance between the intravascular and extravascular is not normal, and there is fluid, the intravascular fluid depletion to the extravascular. Causes of nephrotic syndrome. As I mentioned before, in the proteinuria, there are primary causes of proteinuria. But here the nephrotic syndrome, we have to know not only any proteinuria. We should know that protein should exceed 3.5 gram to say or diagnose that this patient is having nephrotic syndrome. It can primary cause. Primary means we are not knowing the cause exact why this patient. The cause is essential, primary, idiopathic, immune mediated by minimal chain diseases, focal segmental glomerulosclerosis, membranous nephropathy. These all are primary causes, essential causes. And patient can develop nephrotic syndrome if he is having one of these primary glomerular diseases. In secondary cases, also as I mentioned before, in systemic diseases, membranous nephropathy, hepatitis B, Sjogren's syndrome, SLE, systemic lupus erythematosus, if the patient is having nephritis, so he will develop proteinuria, and this proteinuria can reach the nephrotic range. So in this situation, not anyone with SLE will have nephrotic syndrome. But if he is passing more than 3.5 gram protein in 24 hours collecting urine, so he will develop nephrotic syndrome. Diabetes mellitus. Also in this condition, not anyone with diabetes mellitus will develop proteinuria with nephrotic range. But if he has developed nephrotic range, so he is having diabetic nephropathy complicated by nephrotic syndrome. Sarcoidosis. Also, syphilis, cancer. All these causes are secondary causes, and the kidney is involved, causing proteinuria, reaching the nephrotic range proteinuria that is more than 3.5 gram in 24 hours collecting urine. If you have a patient and this patient present with proteinuria, and his protein, we have to check first by deep state. It will be positive. The second step is to send the collected urine in 24 hours or in a day for protein. The patient will have protein of more than 3.5 gram. So this is essential characteristic. The second step is to measure his albumin. Typically, patient with nephrotic syndrome has an albumin level of less than 2.5. The second or the third step here is to check his level of cholesterol, because as we mentioned in definition of nephrotic syndrome, or the consequence of nephrotic syndrome, patient can have, or most probably is having, hypercholesterolemia. So the level of cholesterol is elevated, and mainly the low density lipoprotein, and this is very important. Low density lipoprotein is a high risk. If elevated, is risky for patient to develop cardiovascular diseases. Examine the kidney function, including the electrolytes. Electrolytes, mainly the potassium, calcium, urea, and creatinine as kidney function. It can be elevated, and the kidney is here involved, complicated by nephrotic syndrome. If we are in doubt about the cause of proteinuria, we can do biopsy, and it will help us in immune-mediated diseases or in primary diseases. Kidney disease, biopsy help us to diagnose primary diseases causing proteinuria with nephrotic range proteinuria. Autoimmune markers, ANA, antinuclear antibody, supporting the organ for diagnosing of systemic lupus, globulin, serum electrophoresis for diagnosing of multiple myeloma, cancer, blood cancer, or plasma cell cancer. If the patient, treatment here is guided on the controlling of the disease. That means we have to control the disease. If the patient is having diabetes, we have to control properly his diabetes. If the patient is having systemic lupus erythematosus, we have to control the features of systemic or control the SLE with drugs, certain drugs. Each disease has its certain medication to control it. If the patient is having multiple myeloma, we have to manage it. If the patient is having hepatitis B or C, we have also to manage it. This first. But there is also treatment to control the nephrotic range proteinuria, mainly in patients who are having primary proteinuria or primary nephrotic syndrome, or if the causes are primary glomerulus causes. Here we have to start mainly in the adult people. We have to start with immune suppression drug. Prednisolone essential is to be given first. 1 to 2 milligram per kilogram a day for 6 weeks. With control of the protein in the urine. Rapid controlling. Check the protein in the urine. And you will find in primary, in the majority of patients, you will find that the protein is decreased. After finishing these 6 weeks, then start tapering. Tapering, you should not stop prednisolone abruptly. No, prednisolone should be tapered 5 milligram a week. If the patient is taking 60 milligram a day, after 6 weeks, taper it. Each week 5 milligram, 55 then daily. Next week 50, next week 45, next week 40, and so on. But if we then decrease the prednisolone and the patient is having relapsing, here we have to continue prednisolone 2 milligram per kilogram a day till urine becomes negative for protein. 1 month, 2 months, 3 months, till we find that the protein check, recurrent check, periodic check of protein, 24 hours collecting urine, until we get that by dipstick the protein is negative. Here we have then to start decreasing the prednisolone, then by 1.5 milligram per kilogram a day for 4 weeks, and then tapering. If the patient has tapering, as I mentioned before, 5 milligram each week, but after 4 weeks, first 2 milligram per kilogram day till the protein become negative by dipstick. Then 4 weeks, 1.5 milligram, and then tapering. If the patient then developed relapse again, it's called frequent relapse. Here we have to add cyclophosphamide or cyclosporine or levamisole to the prednisolone, and in general it will be respected. On the same time, from the beginning, we should control the blood pressure, because hypertension will, if the patient is still hypertensive, we cannot control proteinuria properly. Which drugs are here advisable? ACE inhibitors, such as enalapril, lamipril, or angiotensin blocker, such as losartan, valsartan, telmisartan. Because these drugs are shown to decrease the protein loss. I mean, this drug, independently for blood pressure control, these drugs are helpful in controlling blood pressure, but at the same time this drug can help us in decreasing protein loss. So this drug work parallel, blood pressure controlling and decreasing protein loss. And because of that, these drugs are preferred to be given unless there is contraindication of ACE. ACE contraindication, we should know what are the contraindications for angiotensin converting enzymes, inhibitors, or angiotensin blocker. By this way, we will control the nephrotic syndrome, and in many cases, mainly in the children, the remission is, the percent of remission is high. In children, remission is very good and can be cured. In adult people, adult people are on need for long-lasted or long-term, let us say long-term medication with prednisolone, and even also with cyclosporine or levodopa if there is frequent relapses. But in children, the cure rate is very, very good. Thank you. I hope that you understand, and we can discuss this with each other later on in any time. Thank you. في أمان الله. السلام عليكم ورحمة الله وبركاته.